Welcome to the Deep Dive, where our mission is really to peel back the layers of complex topics, extracting the absolute must-know insights so you can truly feel well-informed, ready to engage in any conversation.
Yeah.
Today, we're plunging headfirst into a subject that is as universally relevant as it is, well, intricately detailed: envenomation. We're talking about the world of venomous animals and their profound, often quite frightening impact on human lives. This isn't just about sensational headlines. It's a critical global health challenge that really demands a precise understanding.
And what's truly critical here, and what we'll really unpack today, is that venom isn't some simple poison. It's a remarkably sophisticated biological weapon.
Right.
And understanding its intricate mechanisms is the only way to effectively counter its, well, devastating impact. We'll explore the why behind these effects and what truly makes the difference in patient outcomes, helping you grasp the core principles like the elite professionals in this field. Exactly. And to achieve that level of insight, we're drawing from an exceptionally authoritative source, a comprehensive medical text on the principles and practice of medicine.
A solid foundation.
This isn't a surface-level summary. It's the kind of foundational knowledge that medical experts worldwide rely on. Our mission, as always, is to distill this extensive and authoritative information into clear, actionable understanding for you, so you can navigate the nuances and complexities of envenomation with genuine confidence. Understanding envenomation, a global health challenge. Okay, so let's start with the very foundation then. When we talk about envenomation, it's more than just any bite or sting, isn't it? What's the precise definition that, medical professionals work with?
That's a great place to start because, precision really matters here. Envenomation occurs specifically when a venomous animal injects sufficient venom, either through a bite or a sting, into a prey item or maybe a perceived predator, and that injection then causes demonstrable deleterious local or systemic effects. This is formally defined as a venom-induced disease, or VID.
VID, okay.
And it's crucial to understand that for the animal itself, the primary purpose of that venom is often for predation acquiring and sometimes even pre-digesting their prey.
Ah, interesting. Pre-digesting.
Yeah, some venoms start breaking down tissues right away, but the defensive use, which is typically why a human might get bitten or stung, is often a secondary kind of accidental function.
Right.
So our encounters with these creatures are, for the most part, really unintended consequences of their survival strategies.
And these accidental encounters, as you touched upon, are far more frequent and impactful globally than many people might realize. So what's the real scale of this problem?
Oh, the scale is immense and frankly often underestimated. We're talking about millions of cases of venomous bites and stings annually.
Millions, wow.
Yeah, with a particularly high concentration in the rural tropics where access to medical care is frequently challenging.
Right.
And while the exact global burden remains difficult to pin down because the data collection is often fragmented and inconsistent, well, recent rigorous studies are shedding light on the true numbers.
Like what?
For instance, there was a comprehensive study in India just focusing on snake bites. It estimated a staggering 45,000 snakebite-related deaths in India every year.
45,000 just from snake bites in one country.
Exactly. And that figure dramatically exceeds both previous government estimates and earlier studies. It just underscores how significant this public health problem truly is and how easily its impact can be overlooked.
That's huge.
But it's not just about fatalities, Beyond the immediate deaths, we also have to consider the devastating long-term disability that results from non-fatal envenomation.
Yeah. What kind of disabilities?
Well, it could be chronic pain, severe tissue damage, maybe requiring amputation, disfigurement, or neurological impairments. These disabilities impose profound social and economic costs on individuals, their families, entire communities, impacting their ability to work, sustain their livelihoods, and just live full, productive lives. It's not merely a question of survival. It's profoundly about the quality of life and that long-term recovery.
That makes sense.
And this isn't just a challenge confined to remote rural areas either. There's actually a growing issue globally with the private keeping of exotic venomous animals.
Oh, right. People keeping dangerous pets.
Exactly. Which means that severe cases of envenoming can, and definitely do, present in urban hospitals where doctors might lack specific knowledge or immediate experience with that particular species of snake or spider or scorpion.
I can see how that would be a problem.
Yeah, it highlights the universal need for foundational management principles and readily available expert support regardless of where you are geographically. It really underscores why understanding the basic principles of envenomation management is crucial for medical professionals everywhere.
This also brings up a really critical concept that's often misunderstood, the idea of a dry bite. Can you elaborate on why this distinction is so vital, both for first aid and for medical management?
Absolutely. The concept of dry bites is fundamental. You see,
Yeah.
venom is this incredibly complex cocktail of proteins and enzymes, right?
Right.
And producing it requires a considerable metabolic investment from the animal. It's an energetically expensive resource.
Ah, okay. It costs them something to make it.
Exactly. Because of this, venomous animals often use it sparingly, like a precious commodity. This means that only some bites or stings by venomous animals actually result in significant envenoming,
Okay.
where enough venom is injected to cause those deleterious effects. Others are what we term dry bites, where maybe little to no venom is injected, or perhaps the fangs or stingers don't fully penetrate.
So a bite doesn't always mean venom injection?
Precisely, and this concept is vital for both first aid providers and medical professionals alike, because it fundamentally means that not all exposures lead to a venom-induced disease. Knowing this directly influences the urgency and the type of intervention required.
Right. Avoids unnecessary panic or maybe even harmful interventions.
Exactly. It's not just about being bitten, it's about whether sufficient venom was injected to cause harm. And that requires careful observation, not immediate panic or, unnecessary aggressive action.
That's a crucial distinction, the dry bite concept. What this tells us fundamentally is that a venomous animal encounter doesn't automatically mean a medical emergency, but it always means vigilance is paramount.
Well put.
It's about knowing when to act decisively and when to carefully observe. And when we talk about venomous animals, it's easy to just think of snakes. But the world of envenomation is incredibly diverse. Can you walk us through the major animal groups we're dealing with here beyond just serpents?
Indeed, the diversity is really astonishing. Our source material, specifically Box 8.2 Venomous Animals and Human Envenoming, gives an excellent overview of the key animal groups responsible for human envenomation. We're talking about a wide array of phyla, far beyond just snakes.
Okay, like what?
Well, first we have Chordata. That's a vast phylum, including most vertebrates. In the context of envenomation, this includes venomous snakes, of course, but also various spiny fish-like stonefish or lionfish and stingrays with their venomous tail spines.
Stingrays, right. Ouch.
Then there's Arthropoda, a massive and incredibly diverse group. Here we encounter scorpions, spiders from the relatively benign to the highly dangerous paralysis ticks, and a variety of insects, including bees, wasps, hornets, and ants.
Ticks can be venomous. I thought they just carry diseases.
Some specific types, yes. They inject toxins in their saliva that cause paralysis. We'll get into that.
Okay, what else?
Next, mollusca. This brings us some unexpectedly dangerous creatures, like the beautiful but lethal cone snails and the infamous blue-ringed octopus.
Oh yeah, the tiny octopus that packs a punch.
Exactly. Its small size really belies its potent venom.
Yeah.
And finally, Coelenterata, also known as Cnidaria. This covers jellyfish and other stinging marine organisms like sea anemones.
Jellyfish stings. Definitely familiar with those.
So, while epidemiological estimates certainly reflect the significant importance of snakes and scorpions as the leading causes of severe or lethal envenomation globally,
Right, they get the headlines.
the data for other groups is still quite fragmented. Many of these other animals commonly envenom humans, but their effects are primarily non-lethal, causing discomfort and pain rather than death.
Okay.
However, this is critically important. A few species only rarely envenom humans, but when they do, they carry an extremely high potential for severe or lethal outcomes.
Ah, the rare but deadly ones.
Precisely. This elite group of highly dangerous but rarely encountered species includes animals like box jellyfish, cone snails, blue-ringed octopuses, those paralysis ticks we mentioned, and the Australian funnel web spiders. Their rarity in human encounters often leads to an underestimation of their individual lethal potential.
That makes sense. You don't hear about them often, so you don't realize how bad they can be.
Exactly. And just to clarify something else, social insect stings, think bees, wasps, hornets, they primarily cause death through anaphylaxis.
The allergic reaction.
Right, a severe, life-threatening allergic reaction rather than the direct toxicity of the venom itself. The exception, of course, is in cases of massive, multiple sting attacks.
Like a whole swarm.
Yes, where the sheer volume of venom injected can overwhelm the body's systems, leading to primary venom toxicity becoming a critical, life-threatening factor, independent of any allergic reaction. 2. The intricate science of venom and its devastating effects.
Okay, so to truly understand this battle against envenomation, we need to go microscopic, right? To the very heart of the weapon itself, the venom. What exactly is this mysterious cocktail, and how does it wreak such havoc?
That's an excellent way to frame it. Stepping into the science of venom itself, we really begin to appreciate its incredible complexity. Venom is never just a single substance. It's a remarkably intricate mixture of diverse biochemical components,
Like what kind of components?
primarily various proteins, enzymes, and peptides, which we collectively refer to as toxins.
Toxins, okay.
What's even more fascinating, and definitely challenging from a medical perspective, is that often a single venom can contain not just one, but several separate toxins. Each of these individual toxins is capable of causing distinct adverse effects in humans, targeting different physiological systems.
No. So one venom can attack multiple parts of the body at once.
Absolutely. And to add another layer of biological sophistication, each of these individual toxins can potentially exert multiple effects on the body, simultaneously or sequentially. It's really quite sophisticated.
Wow.
But this incredible biological sophistication comes at a cost, of course. As we mentioned earlier with dry bites, venom production requires a considerable metabolic investment from the animal.
Right. It's expensive to make.
Exactly. This metabolic cost further reinforces why dry bites occur. Venom is a valuable, energetically expensive resource, and it's used sparingly, usually only when absolutely necessary for predation or defense.
That explains why the effects can be so varied, and sometimes confusing for doctors, I imagine, and why every envenomation is really unique. Let's try to break down these clinical effects, like in box 8.3 of our source, into broad categories. Maybe starting with what you see directly on the body.
Right. Good idea.
Yeah.
First, we have the local effects at the actual bite or sting site. These can vary dramatically. I mean, from something trivial like a minor itch or just a pinprick sensation to incredibly severe reactions, indicating massive tissue damage. The common symptoms include intense pain, which can be immediate and excruciating, significant swelling or edema,
Swelling, yeah.
bruising, discoloration of the skin, and even necrosis, which is the complete death of tissue.
Necrosis, tissue death. That sounds bad.
It is. You might also see piloerection, that's basically goosebumps erythema, which is redness, blistering, and of course there's always risk of secondary bacterial infection at the site. But here's where it gets truly counterintuitive, and this is a critical point for understanding envenomation. Some snake bites, particularly from highly venomous species like certain lapids, can present with minimal or even no local effects.
No local effects, not even pain.
Sometimes, yes, minimal pain, minimal swelling, yet they can still cause lethal systemic envenoming.
Wow.
So the absence of a dramatic local reaction does not mean the patient is out of danger. It requires continued vigilance for systemic symptoms.
That's crucial. Okay, so beyond the local site, what about the body-wide reactions, the non-specific systemic effects?
Right. These are more general symptoms that don't immediately point to a specific venom type,
Yeah.
but they signal a body-wide reaction telling you the venom has spread through the system.
Okay, what are those?
They can include things like headache, generalized nausea, vomiting, diarrhea, abdominal pain, changes in heart rate like tachycardia, which is rapid heart rate, or bradycardia, slow heart rate. Fluctuating blood pressure, either hypertension, high blood pressure, or hypotension. Low blood pressure, pulmonary edema, which is fluid in the lungs.
Making it hard to breathe.
Exactly. Also, dizziness, collapse, convulsions, and ultimately severe shock or even cardiac arrest. Among these, shock is an especially critical complication of major envenoming, particularly in cases involving significant local effects and fluid shifts.
And shock can be deadly on its own.
Absolutely. If inadequately treated, shock can rapidly prove lethal, especially in vulnerable people like children.
Okay. Now, here's where it gets really fascinating, I think, as we unpack the specific systemic effects caused by different venom components. You mentioned different toxins. Understanding these seems absolutely critical for both accurate diagnosis and effective treatment, right? Because each toxin dictates a different medical approach.
Absolutely. This is where the biological warfare truly unfolds. Let's start with neurotoxins, which primarily target the nervous system. And these can manifest in two primary, very distinct ways.
Okay, what are they?
First, we have paralytic neurotoxins. These cause what's called flaccid paralysis, meaning muscles become limp and unresponsive.
Paralysis.
And this paralysis can develop with terrifying speed. For instance, with bites from the blue-ringed octopus or stings from cone snails, paralysis can onset in less than 30 minutes.
Half an hour. That's fast.
Incredibly fast, leading rapidly to respiratory failure. For some snake bites, it can progress more slowly, maybe over several hours or even days in the case of paralysis tick envenomation.
So it varies a lot.
It does. For neurotoxic snakes, the paralysis typically begins with the cranial nerves, the nerves controlling things like eye movement, facial expression. A common initial sign is ptosis or drooping eyelids.
Drooping eyelids. That's often the first clue.
Often, yes.
Yeah.
A very subtle but important sign. From there, it can sadly progress to partial and then complete ophthalmoplegia, that's full paralysis of the eye muscles, making it impossible to move the eyes. You might also see fixed, dilated pupils, profuse drooling, and critically, loss of upper airway protection.
Making choking a risk.
A major life-threatening risk, yes. Aspiration of saliva or vomit. From the head, the paralysis can extend down to the limbs, causing progressive weakness and loss of deep tendon reflexes. The neck muscles can also be affected, leading to what's often described as a broken neck sign, where the patient just cannot hold their head up.
Wow.
And ultimately, it culminates in respiratory paralysis affecting the diaphragm, which is, of course, the most immediate life-threatening concern.
Because you stop breathing.
Exactly, requiring mechanical ventilation.
You mentioned presynaptic versus postsynaptic neurotoxins earlier. How does that affect treatment?
Ah, yes, that distinction is vital. It's shown well in Figure 8.2 in our source. Basically, postsynaptic neurotoxins, like alpha-bungarotoxins, just block the receptors on the muscle surface. Think of it like putting tape over a keyhole. Antivenom, if given early enough, can sometimes displace these toxins and reverse the paralysis.
Okay, so antivenom can work there.
Potentially, yes, especially if early. But presynaptic neurotoxins, like beta-bungarotoxins, are different. They cause actual structural damage to the nerve endings themselves, the parts that release the signal.
Damage. So antivenom can't fix that.
Generally, no. Antivenom usually cannot reverse established paralysis from these presynaptic toxins because the damage is already done. Recovery relies on the body physically repairing those nerve endings, which can take days, sometimes weeks.
Days or weeks. Wow. So ventilation is key there.
Absolutely critical. And this highlights the crucial need for early administration of antivenom before major paralysis has occurred, especially for presynaptic toxins, where that window for effective reversal is narrow or just non-existent once the damage is done.
Got it. Okay, what was the second type of neurotoxin?
The second type causes excitatory neurotoxicity. Instead of paralysis, these toxins cause an overstimulation of the nervous system, often leading to what's vividly described as an autonomic storm.
An autonomic storm, what does that look like?
It's characterized by things like profuse sweating, extreme salivation, variable cardiac effects including severe arrhythmias, even cardiac failure, sometimes with associated pulmonary edema.
That sounds intense.
It is. This is notably seen with Australian funnel web spider bites or stings from scorpions like the Indian red scorpion. This type of envenomation can be rapidly fatal due to cardiac collapse, especially common with many scorpions and funnel web spiders.
Okay.
However, it can also cause distressing but maybe less immediately lethal symptoms, like the severe pain and systemic effects seen with widow spiders or banana spiders.
All right. Moving on from neurotoxins, what about myotoxins? Myo meaning muscle.
Exactly. These specialized toxins cause myolysis, which is muscle breakdown. This can be localized just to the bitten limb or more dangerously systemic, affecting skeletal muscles throughout the body.
How would you know that's happening?
Initially, it can actually be silent, no obvious symptoms, but then it presents with generalized muscle pain, tenderness to touch, and dark urine.
Dark urine. Why dark?
That's a telltale sign of myoglobinuria muscle proteins, myoglobin, spilling into the urine because the muscle cells are being destroyed. This is usually accompanied by huge rises in serum creatine kinase, or CK,
CK, yeah.
an enzyme released from damaged muscle cells, which confirms myolysis.
What are the big risks with that kind of muscle breakdown?
Two major risks. First, secondary renal failure as the kidneys just get overwhelmed trying to filter all those muscle breakdown products.
Right, kidney damage.
And second, potentially lethal hyperkalemic cardiotoxicity.
Hyperkalemic. Too much potassium.
Exactly. Damaged muscle cells release excessive potassium into the bloodstream, which can severely disrupt heart rhythm and lead to cardiac arrest.
Okay, very dangerous. What about cardiotoxins? Do they work differently?
Yes, cardiotoxins, as the name suggests, directly or indirectly affect the heart and circulatory system. Their effects can include a significant decrease in cardiac output, the amount of blood the heart pumps, various types of arrhythmias, or irregular heartbeats, and pulmonary edema, that fluid buildup in the lungs. while cardiotoxicity is often a secondary complication of other systemic effects like shock or those electrolyte imbalances from myolysis.
You're right.
For some scorpions, envenomation can cause direct cardiac effects, leading to these critical issues and requiring immediate intervention.
Now, this raises an important question. How can venom affect something as incredibly complex and vital as our entire blood clotting system so profoundly? It's such a sophisticated system, and venoms seem to exploit it in truly diverse and often terrifying ways.
These are the hemostasis system toxins, right?
You're absolutely right. It's a remarkable example of biological precision. The effects of these toxins are incredibly diverse. They can range from rapid coagulopathy, where the blood basically loses its ability to clot effectively, leading to widespread and uncontrolled bleeding,
Bleeding problems.
to, surprisingly, the opposite, thrombosis, which is the formation of abnormal and dangerous blood clots within blood vessels.
So it can make you bleed or make you clot abnormally. Exactly. It depends on the specific venom. If coagulopathy is the primary effect, it might present as easy bruising, spontaneous bleeding from the bite site, maybe from the gums, or from IV insertion sites.
Yeah,
Trying to do surgery in such cases becomes incredibly high risk.
I can imagine.
Conversely, other venoms can cause thrombosis, usually manifesting as deep venous thrombosis, DVT, pulmonary embolus, a clot in the lungs, or even stroke. This is particularly seen with venoms from certain vipers found in the Caribbean or Martinique.
Okay, so how do they actually do this? What are the mechanisms?
The mechanisms are truly fascinating, really illustrating sophisticated biological warfare at a molecular level. There are several ways. One, some venoms contain hemorrhagic metalloproteinases and disintegrants. Think of these like microscopic demolition crews.
Okay.
They directly attack and damage your blood vessel walls, causing leakage of blood. They also degrade the body's ability to form a platelet plug, which is that crucial first line of defense against bleeding. So they disrupt the vessel's integrity. 2. Other venoms possess direct fibrinolytics. These abnormally split fibrinogen, a crucial protein needed for clot formation. This results in poor or unstable clot formation and a severe tendency to bleed.
Makes sense.
3. Then there are the procoagulants. These actually activate specific coagulation factors in the blood clotting cascade, initially promoting the rapid formation of fibrin clots.
So they make you clot faster.
Initially, yes. But here's the twist. They can also overactivate the fibrinolytic system, which is the body's natural clot-dissolving mechanism. This can lead to something called defibrillation.
Defibrillation.
Yeah, essentially, your body's vital clotting factors get used up in this chaotic cycle of clotting and dissolving. This leaves you in a state where you can't form protective clots when you actually need them most, paradoxically leading to bleeding.
That's counterintuitive, but makes a scary kind of sense.
It is. And 4. Finally, there are other toxins that target various other parts of the clotting system. They might act as activators, like plasminogen activators, or as inhibitors of coagulation, such as serpin inactivators or platelet aggregation inhibitors. It's truly sophisticated biological warfare at the molecular level, demonstrating venom's ability to precisely manipulate the body's most fundamental protective systems.
Amazing. And related to that, you mentioned hemorrhagic toxins. How are they different?
Right, building on that, hemorrhagic toxins primarily cause vascular damage, particularly noticeable in the bitten limb. They lead to the extravasation of fluid, essentially, fluid leaking out of the blood vessels into surrounding tissues.
Causing more swelling.
Exactly, significant swelling. And sometimes this can contribute to hypotensive shock, a severe drop in blood pressure due to the fluid loss from the circulation. This fluid extravasation is a significant problem associated with certain snake bites. While their role in causing late-developing capillary leak syndrome, which can also lead to issues like pulmonary edema, is still a bit uncertain, their immediate impact on blood vessels is clear and dangerous.
Okay. And the last category you mentioned was nephrotoxins. Nephro meaning kidney.
Correct. These are toxins that cause renal or kidney damage. Now, in most cases, this kidney damage is actually secondary to other systemic effects,
Like what?
like prolonged shock, extensive rhabdomyolysis leading to myoglobinuria, that muscle breakdown we talked about, or severe disseminated intravascular coagulation, DIC, which can compromise blood supply to the kidneys.
So the kidneys get damaged as a consequence of other problems.
Usually, yes.
What?
However, some species, like Russell's vipers in certain geographical populations, can cause direct primary renal damage with their venom.
Okay. So how does kidney damage show up?
The presentation is similar in both scenarios, secondary or primary. You see observable changes in urine output. Maybe polyuria, which is excessive urination, indicating the kidneys are failing to concentrate urine properly.
Uh-huh.
Or oliguria, which is reduced urination. Or even anuria, no urination at all. This is often accompanied by rises in creatinine and urea levels in the blood, which are key indicators of kidney dysfunction.
Right, the blood tests.
And in cases with significant intravascular hemolysis, that's red blood cell destruction, secondary renal damage is particularly likely because the kidneys are burdened trying to filter out all the damaged red blood cells.
So as you can see, the specific clinical effects of envenomation are incredibly diverse, just as diverse as the animals that cause them, and each requires a really precise understanding for effective intervention. 3. The crucial initial response. First aid and hospital assessment. Given the potentially devastating and really varied effects we've just discussed, it seems clear that the initial response, particularly first aid, must be absolutely critical in determining the patient's outcome. But you often hear about inappropriate and even dangerous practices being used. What should a person do, or maybe more importantly, what should they not do in that crucial first window?
You're highlighting a key challenge there. It's not just about doing something, it's about doing the right thing. And just as important, avoiding the wrong things.
Oh.
Let's detail what is universally recommended and what should be strictly avoided.
Okay.
For most forms of envenoming, the recommended first aid is actually quite straightforward. The main aims are to minimize venom spread and support the patient's vital functions.
Makes sense.
So first, the patient should be kept as still as possible. Reducing muscle activity helps slow the pumping of venom through the lymphatic system.
Keep still. Got it.
Second, the bitten limb should be immobilized, ideally with a splint, again, to minimize venom dissemination.
Immobilize the limb. Okay.
And third, and crucially, vital systems must be supported. This means ensuring a patent or open upper airway and providing respiratory support if required because neurotoxicity can quickly compromise breathing.
Support breathing if needed. Basic ABCs.
Exactly. Now, for some animals, notably specific snake species in certain regions, a pressure bandaging technique is highly recommended.
Pressure bandaging, how does that work?
Well, it can involve a local pressure pad bandage right over the bite site, which is common for elapid snake bites in Myanmar, for instance. Or it could be a broader pressure immobilization bandage, which is standard practice in Australia and New Guinea for bites from their highly neurotoxic snakes and funnel web spiders.
And why does pressure help there?
It's effective because a significant proportion of venom, especially those venoms containing larger molecular weight toxins like many snake venoms, is primarily transported from the bite site via the lymphatic system, not immediately by the bloodstream.
Ah, the lymphatics. Okay.
So applying consistent pressure helps to slow this lymphatic spread, effectively delaying the onset of systemic envenoming and buying precious time for the patient to reach medical care.
That makes a lot of sense. Okay, so that's what to do. What about the things people shouldn't do? The dangerous stuff.
Right. This is critical.
Right.
Because these practices can cause far more harm than the bite itself. Ineffective or downright dangerous first aid practices include suction devices. Those little kits you can buy. They do not remove significant venom, and they can cause local tissue damage.
So those kits are useless.
Pretty much, yes, and potentially harmful. Also, the old cut and suck method. This is completely ineffective at removing venom and just introduces a high risk of infection and more local tissue damage.
Right, definitely don't do that.
Applying local chemicals to the bite site, things like potassium permanganate. They can cause chemical burns and offer absolutely no benefit against the venom.
Okay.
Using snake stones. These are various objects, often porous rocks or similar, placed over the bite based on folklore. They are completely useless and only delay proper medical care.
Snake stones. Wow. Okay, avoid folk remedies.
Absolutely. And, critically, tourniquets should never be used.
Never. Why are they so bad?
This is a frequent and incredibly dangerous mistake. Tourniquets, if they're applied too narrowly or too tightly or left on for too long, have the potential to cause catastrophic distal limb injuries in snakebite cases.
Like cutting off blood flow completely.
Exactly, leading to severe damage, nerve compression, or even the loss of the limb due to ischemia, the lack of blood flow. Furthermore, there's a serious life-threatening risk of sudden, overwhelming envenoming when a tourniquet is finally removed.
How so?
Because all the venom that's accumulated in the limb while contained is suddenly released into the systemic circulation all at once. It can cause a massive, rapid systemic reaction. It's a practice that carries far, far more risk than any perceived benefit.
That's a really powerful warning about tourniquets. Okay, so once appropriate first aid, the right first aid has been administered, the next critical step is patient transport. Timeliness here seems paramount. But what are the considerations beyond simply getting to a hospital quickly?
Timeliness is indeed paramount. Medical assessment and intervention need to be obtained at the earliest possible opportunity. So any delay in transporting the patient to a medical facility should be avoided at all costs.
Get there fast.
Yes, but it's not just about speed. Severely envenomed patients can develop life-threatening problems like shock or respiratory failure during transport.
Ah, right. Things can get worse on the way.
Exactly. So ideally, the transport method used should allow for the management of these problems en route. This means, if possible, transport should allow for things like airway management, giving fluids, and monitoring the patient.
Which isn't always possible, I guess, especially in remote areas.
Precisely. In resource-poor environments, simple solutions for rapid transport have been successfully employed, like using motorbikes, with the patient supported between the driver and another person.
Okay, better than nothing.
Much better than delaying, yes. But it's important to acknowledge the limitations of such methods. While they offer speed, they obviously cannot adequately cope with a patient who develops airway compromise or respiratory failure, say, from evolving neurotoxicity during the journey. It's a really challenging balance between speed and the ability to provide that critical life-sustaining care en route.
Yeah, tough choices.
Precisely. So once a patient arrives at a health station or hospital, there are two immediate and paramount priorities for the medical team. First, and this always takes precedence, is identifying and treating any life-threatening problems. This is the resuscitation phase.
Stabilize first.
Absolutely. Clinicians must actively look for and immediately address signs of circulatory shock or hypotension, any evidence of airway and/or respiratory compromise, which is often secondary to that flaccid paralysis from neurotoxic venoms. Major bleeding, especially internal or intracranial hemorrhage, which can be rapidly fatal, and any impending limb compromise resulting from inappropriate first aid, like a badly applied tourniquet. And it's vital to be extremely cautious here, because removing a tourniquet, while necessary, can lead to that sudden surge of venom and subsequent severe envenoming we talked about.
Tricky situation.
Very. It's also important to note that in patients with severe neurotoxic flaccid paralysis, even if they can still maintain enough respiratory function for survival, their clinical assessment might falsely suggest irreversible brain injury.
How so?
They might have things like fixed dilated pupils, absent reflexes, no withdrawal response to painful stimuli, no limb movement, maybe a fixed forward gaze with gross ptosis, all looking terrible.
Yeah.
However, the patient may in fact be fully conscious and aware, but simply unable to move or communicate. Locked in, essentially. This is a critical diagnostic trap to avoid.
Oh, wow, that's scary. Okay, so resuscitation first. What's the second priority?
The second priority, once those immediate life threats are managed, is determining whether envenoming is actually present and if it requires urgent treatment. As in all areas of medicine, a comprehensive assessment begins with a good history, a careful and targeted physical examination, and where appropriate, specific laboratory testing.
Okay, let's break that down. The history, what are the key questions to ask?
Right. Clinicians need to ask things like, when was the exposure? The time from bite to symptom onset is crucial. What did the organism look like? If they saw it, a detailed description, size, color, markings can help identification, though patient descriptions are often unreliable.
People might misidentify it easily, I suppose.
Very easily, yes. Also, what were the circumstances? On land, in water, specific environment. Was it provoked or accidental? Was there more than one bite or sting? This obviously impacts the potential venom dose. What first aid was used? When, for how long, what methods? This is vital for assessing any iatrogenic injury, like from a tourniquet, and the potential for delayed venom release if pressure was applied. What symptoms has the patient experienced? Both local pain, swelling, and systemic headache, nausea, dizziness, paralysis, bleeding. Are there any symptoms suggestive of systemic envenoming, like developing paralysis, signs of rhabdomyolysis, muscle pain, dark urine, or coagulopathy, bleeding from gums, old wounds? And finally, any significant past medical history, current medication use, or allergies, including any past exposure to antivenom or venom, as this impacts the risk of allergic reactions to treatment.
That's a lot to cover. Are there challenges in getting that history accurate?
Oh, definitely. Sometimes patients may be unaware they've even been bitten or stung, leading to a misleading account. In regions where keeping or handling venomous animals is illegal, patients might be hesitant to provide a truthful history, fearing legal trouble.
Ah, yeah, the exotic pet issue again.
Exactly. And critically, Misidentification of the species, whether it's a snake, scorpion, or a spider, can have dire consequences if the wrong antivenom is used, as antivenoms are often highly species-specific.
Okay, so history is key, but tricky. What about the clinical examination? What are doctors looking for?
They're looking for specific findings outlined comprehensively in our source. This includes assessing cranial nerve function, looking for that cytosis, drooping eyelids, eye movement issues, ophthalmoplegia, or facial weakness, mouth and gums, checking for bleeding, profuse drooling, or signs of aspiration, chest findings, listing pulmonary edema, assessing diminished respiration or signs of respiratory muscle weakness, the bite or sting site itself, observing pain, swelling, bruising, discoloration, blistering, or necrosis, level of consciousness and mental status, eye signs, things like miosis, constricted pupils, or mydriasis, dilated pupils, increased lacrimation, tearing, or even corneal injury if venom was spat in the eyes.
Spitting venom.
Right. Vital signs, blood pressure, pulse, respiration rate, oxygen saturation, and any cardiac dysrhythmias on monitor, muscle strength and tenderness. Assessing for that flaccid paralysis or myolysis, lymph nodes, checking if they're enlarged, abdominal pathology, looking for tenderness, rigidity, or other signs of internal issues, reflex changes, assessing deep tendon reflexes, sweating. Profuse sweating can be a sign of that autonomic storm. A cluster of these clinical features taken together can strongly suggest a particular type of envenoming and really help guide the initial management.
Okay, that makes sense. Looking for patterns.
Exactly. And it's important to reiterate that even with bites or stings from dangerously venomous animals, a significant proportion will be dry bites and won't require antivenom.
Right.
The time it takes for the first symptoms and signs of envenomation to appear is highly variable. It depends on the animal species, individual patient factors like how much venom was injected, where the bite was, the patient's activity level.
Lots of variables.
Huge number. It can range from just a matter of minutes post-bite or sting, particularly with very potent neurotoxic venoms, to as long as 24 hours later in some cases, especially with venoms that cause coagulopathy or more insidious, slow-developing effects. Therefore, if the initial assessment is normal, it must be repeated multiple times, typically every 4 to 6 hours, during that first 24 hours to catch any delayed onset of symptoms or signs.
So you can't just check once and say they're fine.
Absolutely not. Vigilance for 24 hours is key. Furthermore, some types of envenomation might not cause obvious symptoms or signs at all, or they might appear very late, long after the optimal time for treatment has passed, becoming apparent only through specific lab testing.
Wow. Okay, so that brings us to bedside and laboratory tests. What are the crucial ones?
These are absolutely crucial for confirming envenoming and guiding treatment. First, there's the 20-minute whole blood clotting test, 20 WBCT. This is a brilliantly simple yet incredibly powerful and standardized bedside test for coagulopathy.
So you can do it right there without a lab.
Exactly. It's applicable even in areas with limited health facilities, making it a cornerstone of snakebite management in many parts of the world.
How does it work? Can anyone do it?
It's quite simple to perform correctly. First, you get a clean, dry glass container like a test tube, or even a small glass vial. Plastic doesn't work as well for activating clotting.
Glass, okay.
Then you place 2-3 millimoles of venous blood into it, making sure it's from a good venopuncture to avoid getting tissue factors mixed in, which could cause a false positive clot. Then you let the blood stand completely undisturbed for exactly 20 minutes at ambient temperature. It's critical not to shake or agitate it.
Let it sit.
Exactly. After 20 minutes, you gently invert or tip the container to check for the presence of a blood clot. If a firm, stable clot has formed, it's a negative test, meaning no significant coagulopathy is present.
Okay.
If the blood remains liquid and no clot forms, or maybe only a very flimsy, unstable clot, it's a positive test, indicating a significant coagulopathy. This simple test is a crucial indicator of major envenoming for many snake species.
That's incredibly useful, especially in remote areas. What else?
Urine examination is also critical. Looking for hematuria, which is blood in the urine that might indicate coagulopathy or direct renal damage, and looking for that dark urine, which is highly suggestive of myoglobinuria from rhabdomyolysis, that muscle breakdown.
Check the pee. Got it. What about more standard laboratory investigations if you have a lab available, particularly for snakebite?
Yes, for more equipped facilities, a comprehensive screen for envenoming typically includes a full blood count, FBC. To check for anemia from bleeding, changes in white blood cell counts indicating infection or inflammation, and platelet counts looking for thrombocytopenia, low platelets, a coagulation screen. More detailed tests like prothrombin time, PT, activated partial thromboplastin time, APTT, and fibrinogen levels to precisely assess clotting ability, urea and electrolytes, UNE, creatinine, to check kidney function and look for electrolyte imbalances, especially potassium checking for hyperkalemia from myolysis, creatine kinase, CK, to assess the extent of muscle damage from myotoxins, an electrocardiogram, ECG, to monitor heart function and detect arrhythmias, particularly with cardiotoxic venoms or that risk of hyperkalemia, and potentially lung function tests, peripheral oximetry, or arterial blood gases if there's potential or established respiratory failure to gauge the severity.
Okay, quite a comprehensive panel there.
Yes. These simple bedside tools like the 20WBCT, combined with a meticulous history and examination, and backed up by lab tests where possible, are all essential for timely diagnosis and management, particularly in those challenging environments where advanced diagnostics might not be available. 4. Tailored treatment approaches. Antivenom and beyond.
Okay, so once a diagnosis of likely envenoming has been made, the urgent decision often revolves around whether to administer antivenom. But what does antivenom actually do, and what are its limitations? It's not quite a magic bullet that fixes everything, is it?
You're absolutely right. Antivenom is often the most important specific treatment for envenomation. But, this is crucial, it may not be the only crucial treatment, and sometimes for a critically ill patient, it's not even the most immediate priority.
Meaning resuscitation comes first.
Always. For example, consider a severe snake bite from a potentially lethal species like Russell's viper. The patient might present with significant local effects, edema, blistering, necrosis leading to massive fluid shifts and shock. Simultaneously, they could have systemic effects like intractable vomiting, severe coagulopathy, leading to widespread bleeding, progressive paralysis, and acute secondary renal failure.
A real mess.
A complete clinical disaster. Now, specific antivenom will be absolutely required to neutralize the circulating venom, reverse the coagulopathy, and potentially prevent the worsening of paralysis and reduce vomiting. But it will not significantly reverse existing local tissue damage, nor will it directly treat established renal failure or the shock that might result from fluid loss or bleeding.
So it stops the venom but doesn't undo all the damage already done.
Precisely. Those complications will require extensive supportive care, aggressive intravenous fluid therapy, possibly respiratory support with mechanical ventilation, renal dialysis for kidney failure, meticulous local wound care, maybe antibiotics to prevent infection. It demonstrates that each venomous animal causes a particular pattern of venomation, necessitating a highly tailored and comprehensive response that goes way beyond just giving antivenom.
Okay, so tell us about antivenom itself. How is it made? How does it work?
Right. Antivenom, sometimes inaccurately labeled as anti-snake venom or ASV, is the primary specific treatment. Its mechanism of action is really quite elegant and targeted. It's made by hyperimmunizing an animal, usually horses or sometimes sheep.
Immunizing them with venom?
Yes, with small, non-lethal doses of specific venoms. The immunized animal then produces antibodies against these venoms. These antibodies are then harvested from the animal's plasma and refined.
Okay.
Once administered, usually intravenously to a bitten patient for rapid distribution, these antibodies bind to the venom toxins circulating in the body. This binding effectively renders the toxins inactive or allows their rapid clearance from the bloodstream by the patient's immune system.
So it neutralizes the venom?
Essentially, yes. Now, antivenom is available only for certain medically important venomous animals, and it's critical to understand that it cannot reverse all types of envenoming or all established damage. With a few exceptions, it is typically given intravenously, and it's absolutely critical to have adrenaline or epinephrine ready.
For allergic reactions?
Exactly. In case of anaphylaxis, which is a severe, potentially life-threatening allergic reaction to the antivenom proteins themselves, even with careful administration.
Okay. So when should antivenom be used? What are the indications?
It should only be used when clearly indicated, and these indications vary widely between different venomous animals, reflecting the specific dangers of their venoms. As outlined in box 8.7 of our source, general indications for antivenom include things like shock or cardiac collapse, signs of circulatory failure, respiratory compromise, difficulty breathing, signs of respiratory muscle weakness, or developing paralysis, rapidly increasing swelling of the bitten limb, indicating aggressive local venom effects, active bleeding, especially from multiple sites or internal bleeding, indicating coagulopathy, intractable nonspecific symptoms, such as recurrent vomiting, severe abdominal pain, or other systemic distress that isn't responding to general supportive care.
Okay, those are general signs of severe illness. What about specific effects?
Yes, specific indications tied to known venom actions include developing paralytic features, like that ptosis, ophthalmoplegia, or limb weakness we talked about, developing rhabdomyolysis, confirmed by muscle pain and rising CK levels, developing coagulopathy, confirmed by tests like the 20-WBCT or a lab coagulation screen, developing renal failure, indicated by rising creatinuria or changes in urine output, developing neuroexcitatory envenoming, seen in those scorpion or funnel web spider stings characterized by autonomic storm symptoms.
I got it.
And it is absolutely paramount that the correct antivenom is used for the identified or suspected species at the appropriate dose, as doses vary widely by antivenom and species. In some situations, particularly in the Indian subcontinent, pre-treatment with subcutaneous adrenaline might be given to try and reduce the chance of anaphylaxis to the antivenom, though this practice is debated in other regions.
Right, using the right key for the right lock, essentially. Now let's talk about the crucial limitations and nuances of antivenom. This seems like where a deep understanding really matters.
Absolutely. This is critical. Neurotoxic paralysis. As we discussed earlier with pre- and postsynaptic toxins, antivenom can sometimes reverse postsynaptic paralysis, the receptor blockers. However, it will not usually reverse established presynaptic paralysis, the nerve-ending damage. Remember figure 8.2.
Right, the structural damage.
Exactly. So again, early administration is key, especially for presynaptic toxins where the window for reversal is narrow or non-existent once damage is done. For these, the primary treatment becomes prolonged mechanical ventilation. Coagulopathy. Venom-induced coagulopathy is generally best reversed by antivenom. However, even after all the venom is neutralized, there can be a significant delay, maybe several hours, before normal coagulation is fully restored.
Why the delay?
Because the body needs time to physically resynthesize all the clotting factors that were consumed by the venom. Therefore, clinicians are generally advised not to give more antivenom just because the clotting tests haven't fully normalized within the first hour or 3, unless there's clear evidence of ongoing active venom effects.
Okay, be patient with the clotting recovery.
Exactly. And thrombocytopenia, that low platelet count, might also persist for days despite effective antivenom. Other effects. The role of antivenom in reversing established rhabdomyolysis and renal failure is uncertain. It's likely more effective at preventing their progression if given early, rather than reversing existing damage. And while antivenom may help limit local tissue effects or injury in the bitten limb, this effect is quite variable and highly time-dependent. It's most effective when given very early, before significant tissue damage has already occurred.
So timing is everything for local effects, too.
Very much so. Neuroexcitatory envenoming. This type, the autonomic storm, can respond very well to antivenom, particularly for Australian funnel web spider bites and stings, from medically important scorpions in Mexico, South America, and India. However, there is ongoing controversy about its effectiveness for some species, particularly certain North African and Middle Eastern scorpions, where alternative treatments focusing on cardiac support are sometimes preferred. Necrosis. The role of antivenom in definitively limiting local venom effects, including the development of necrosis or tissue death, remains controversial. While some studies suggest a benefit, it's most likely to be effective only as given very early in the course of envenoming, ideally within a few hours of the bite, before irreversible damage sets in.
Okay, and what about adverse reactions to the antivenom itself?
Yes, it's vital to remember that all patients getting antivenom are at risk of both early and late adverse reactions. Early reactions include anaphylaxis, which can happen rapidly and isn't always the classic IgE-mediated type and pyrogenic reactions like fever. Delayed reactions include serum sickness.
Serum sickness, what's that?
It's an immune complex-mediated reaction that can occur days to weeks after antivenom administration. It can cause fever, rash, joint pain, and sometimes kidney issues. Something to watch out for later.
Right. Okay, so beyond antivenom, what other treatments are crucial in managing envenomation, especially when antivenom has limitations or maybe isn't available?
A number of non-antivenom treatments are indeed vital and often life-saving supportive measures. Anticholinergics. These are medications like neostigmine, used as an adjunctive treatment specifically for postsynaptic paralysis.
The type antivenom might help with too.
Exactly. They work by inhibiting the enzyme acetylcholinesterase, which increases the amount of the neurotransmitter acetylcholine at the neuromuscular junction. This helps overcome the blocking effect of those postsynaptic neurotoxins. Prazosin. This is an alpha-adrenoceptor antagonist. It was historically used quite a bit in managing the severe hypertension or pulmonary edema seen in scorpion sting cardiotoxicity, particularly from the Indian red scorpion. However, now, specific antivenom is generally the preferred treatment for this specific issue, as it targets the underlying venom causing the catecholamine storm.
Okay, so less common now, maybe.
For that specific indication, yes, where antivenom is available, antibiotics. Contrary to what many people assume, antibiotics are not routinely required for most venomous bites or stings, as venom itself is generally sterile. However, there are exceptions. Some animals, like certain South American pit vipers or stingrays, frequently cause significant wound infection or abscesses due to the nature of their bite or the contaminated environment. So empirical antibiotic use might be needed there. And while tetanus is always a risk with puncture wounds, like snake bite, intramuscular tetanus toxoids should not be given until any coagulopathy has been effectively reversed.
Why wait?
To prevent serious bleeding complications, like a large hematoma, at the injection site if the blood isn't clotting properly.
Ah, makes sense.
Mechanical ventilation. This is a truly life-saving intervention. It is absolutely vital for established respiratory paralysis, especially if it's from those presynaptic neurotoxins that aren't reversible by antivenom, or if the paralysis is simply profound. Patients might require mechanical ventilation for prolonged periods,
How long?
sometimes up to several months in severe cases, to allow the patient to recover from diaphragm paralysis as those nerve endings slowly regenerate. It's a real testament to modern critical care. And now, here's where it gets really interesting, because this is an example of an intervention that can be utterly disastrous if misused. Fasciotomy.
Fasciotomy. That's surgery to relieve pressure, right?
Yes, it's a surgical procedure to relieve pressure within a muscle compartment. But it is an overused and often disastrous surgical intervention in snakebite cases. It's frequently associated with poor functional outcomes for the patient, things like severe scarring, nerve damage, and limb dysfunction.
So it often makes things worse.
It certainly can, if not done for the absolute correct indication. It's typically considered for potential compartment syndrome or just severe limb swelling, but its indications are extremely narrow in the context of envenomation.
So when should it be done?
It should be reserved as a treatment of last resort, and it must only be used in cases where compartment syndrome is definitively confirmed by objective intercompartment pressure measurement, actually measuring the pressure inside the muscle compartment.
Not just based on how swollen it looks.
Absolutely not. Furthermore, it should only be performed after less invasive measures, like limb elevation, appropriate antivenom administration, if indicated and if it might limit swelling, and resolution of any systemic complications have been attempted. And critically, after anticoagulopathy has been completely resolved.
Can't do surgery if they can't clot.
Performing a fasciotomy in a patient with uncorrected coagulopathy can lead to catastrophic, uncontrolled bleeding and subsequent shock, often leading to far worse outcomes than the envenomation itself. This really highlights how precise and thoughtful interventions must be when dealing with envenomation, where an overzealous or incorrect action can cause much more harm than the original injury.
That's a very powerful point about surgical interventions and the nuances involved. And finally, once the acute phase is over, what about follow-up care for patients who've experienced significant envenomation? Is it just go home and rest?
Definitely not. Follow-up is crucial for comprehensive care. Cases with significant envenomation, and especially those who have received antivenom, should be carefully followed up, often for weeks or even months,
Why so long?
to ensure that any acute complications have fully resolved, like kidney function returning to normal or neurological deficits improving. And importantly, to identify any delayed envenoming, which can sometimes manifest days or even weeks after the initial bite or sting, things like delayed coagulopathy, persistent neurological issues, or those serum sickness reactions to antivenom. Comprehensive care doesn't end when the patient leaves the hospital. It extends into a period of watchful monitoring and potentially rehabilitation. Envenomation by specific animal groups, a global perspective.
Right. Now that we've established the fundamental principles of envenomation, from the venom itself to initial medical management, let's zoom in a bit and unpack the specifics of different animal groups. This seems like where understanding the local fauna becomes absolutely paramount for effective response. You've hinted at the types of venom, their clinical effects, even the right antivenom can vary dramatically based on geography, making this a true global puzzle.
Precisely. Let's start with venomous snakes. They represent the single most important cause of envenomation globally. They affect millions of humans annually, resulting in substantial numbers of deaths and countless patients left with long-term disability, as we noted earlier.
Millions. Yeah.
Of the over 3,000 known snake species, more than 1,000 are considered venomous or produce significant oral toxins. The most important venomous snake families from a clinical perspective are the Viperidae, that includes typical vipers and pit vipers, known for their long hinged fangs and often those heat-sensing pit organs, and the Elapidae. This is a diverse family encompassing cobras, kraits, mambas, coral snakes, sea snakes, and all Australian snakes. We also find dangerous species within the Atractospididae, like the side-fanged burrowing vipers of Africa and the Middle East, and the non-front-fanged colubrids, or NFF sea snakes, a diverse group including the back-fanged boomslang and vine snakes of Africa, and the keelbacks of Asia.
So many different families. Now, this raises an important question. How much does geography really dictate the risk and management of snakebite?
The answer is, it dictates almost everything. The specific snake fauna in any given region directly determines the likely animals involved in bites, and consequently, the nature and risks of the envenomation. Our source material highlights this beautifully in boxes 8.4 through 8.6, showing how the prevalent species, and thus the typical clinical syndromes, differ dramatically across continents like Asia, the Americas, Australia, and Africa, Europe.
So location, location, location is key for snakebite.
Absolutely. For example, in the Indian subcontinent, the major snakebite risks are often traditionally attributed to the so-called Big Four.
The Big Four, who are they?
That's cobras, Naja Naja, kraits, Bungarus spp, Russell's viper, Dalboy roselli, and saw-scaled vipers, Aeschylus carinatus. However, this traditional list, while historically significant, is actually quite misleading and a dangerous oversimplification today.
Why misleading?
Because it critically omits other highly important snakes, like the hump-nosed vipers, Hypnil spp, the majestic king cobra, Ophiophagus hanna, and various green pit vipers, Trimersurus spp, all of which can cause severe or lethal envenoming in the region.
And the problem is?
The current Indian envenoms are often not adequately effective against bites from these omitted species. This can lead to treatment failures if clinicians rely solely on that outdated Big Four paradigm.
Wow, okay. That's a huge issue.
It is. And critically, even within the same snake species, there could be major geographical variation in venom composition and the resulting clinical features of envenoming. This is a profound challenge for antivenom development and clinical practice.
So a Russell's viper bite in one place might be different from another.
Dramatically different. Take Russell's viper, Dalboya STP. It's wide-ranging and medically significant. Sri Lankan specimens can cause not only the classic severe coagulopathy, hemorrhage, local bite site injury, and acute kidney injury, but also significant rhabdomyolysis and flaccid paralysis. However, Indian populations of the same snake species are not typically associated with either rhabdomyolysis or paralysis. Instead, in parts of southern India, they may uniquely cause anterior pituitary hemorrhage, leading to long-term endocrine dysfunction, and/or capillary leak syndrome, resulting in hypotensive shock and widespread vascular leakage, including severe pulmonary edema.
That's incredibly different for the same species.
It is. Capillary leak syndrome is also frequently seen with populations of Burmese Russell's viper, where acute kidney injury is especially common and severe. This means that antivenom raised against venom from one population of these snakes is often poorly effective or even ineffective against bites from snakes from other regions, even if they are technically the same species.
So the antivenom might not work if it's from the wrong region?
Exactly. Similar issues exist with saw-scaled vipers, Echis piaf. They're spread from West Africa across the Middle East to the Indian subcontinent, and each of the several species has unique venoms that may not be neutralized by antivenoms raised against other Echis species. Indian antivenoms, for example, are known to be ineffective against African Echis species. This just underscores that in managing snakebite, it is critically important to choose the appropriate antivenom, and to understand that even an antivenom claiming to cover a given species might not be effective against all geographical variants of that species.
That adds so much complexity.
It really does. Furthermore, it's unwise to assume that we know everything about envenoming by snakes, because new clinical information and syndromes are continually emerging as more detailed studies are carried out.
Like what kind of new thing?
For instance, crate bites, Bungarus spp, were long associated primarily with painless bites, followed by devastating flaccid paralysis and high mortality, with little local effect. We now know there's venom diversity even within these species. At least some can cause significant rhabdomyolysis and/or severe hyponatremia. And while bites may indeed be painless, systemic envenomation can cause severe abdominal pain in some patients, a symptom not previously widely recognized. With cobra bites, Naja spp, the clear distinction between non-spitting, predominantly neurotoxic species and spitting, less neurotoxic species that cause prominent local necrosis, is becoming less clear. Non-spitting cobras are now known to spit venom in parts of their range, like Nachikawuthia in West Bengal, and may cause local necrosis in addition to paralysis.
So the old rules are changing.
They are. Even previously clear diagnostic indicators for envenomation, like Russell's vipers and saw-scaled vipers causing coagulopathy, have become less certain as we learn more. It is now known that other snakes, such as hump-nosed vipers, Hypnel spp, and green pit vipers, Tromera surisme spp, found in similar regions, can also cause marked coagulopathy. Yet they are often not covered by available antivenoms, making diagnosis and treatment really challenging.
Right.
Even snakes previously considered harmless or medically insignificant, like the keelbacks in Asia, Rhabdophis spp, can cause life-threatening coagulopathy, further complicating the diagnostic and management process, especially as specific antivenom against these snakes is currently available only in Japan. The field is truly dynamic and constantly evolving.
It really sounds like it. Okay, moving on from snakes. What about scorpions? You said they're second only to snakes globally?
That's right. Scorpions are a major cause of venomous impact on humankind globally, causing significant morbidity and mortality, especially in children. Most medically important scorpions belong to the Buthidae family and possess complex neuroexcitatory venoms with highly specific ion channel toxins.
Neuroexcitatory, like that autonomic storm.
Exactly. Classically, stings by these Buthid scorpions cause moderate to severe local pain, often with tingling or numbness, and a rapid onset systemic envenoming. This leads to that catecholamine storm-like syndrome, a massive release of adrenaline and noradrenaline.
And the effects are?
Rapid fluctuations in heart rate, tachycardia or bradycardia, severe changes in blood pressure, hyper or hypotension, profuse sweating, excessive salivation, coeluria, cardiac dysfunction including arrhythmias and myocardial injury, and severe pulmonary edema due to left ventricular failure. There's a significant risk of cardiac collapse, particularly in children, making these stings life-threatening emergencies. Other clinical features can vary depending on the specific scorpion species.
Are there any exceptions to that pattern?
Yes, a fascinating and clinically important one is the Iranian scorpion, Hemoscorpius lepturus, found mainly in southwest Iran. Its sting causes a remarkably different presentation.
How so?
An initial minor sting, often described as just a pinprick, but this is followed by the progressive development of severe bite site or limb necrosis.
Necrosis again.
Yes. And this local damage is accompanied by a potentially lethal systemic envenoming characterized by intravascular hemolysis, destruction of red blood cells, disseminated intravascular coagulation, DIC, secondary renal failure, and shock. A completely different picture.
Wow. And how is scorpion sting management handled? Does it vary?
It varies significantly by species and region. In Latin America and India, specific antivenoms are routinely used, and their implementation has been associated with dramatically improved outcomes and significant falls in mortality rates.
So antivenom works well there?
Generally, yes. In contrast, in parts of North Africa, there's been a shift away from a past reliance on antivenom towards focusing more on cardiac support and symptomatic treatment. This has arguably led to poorer outcomes, highlighting the ongoing debate and the importance of evidence-based regional guidelines. In Iran, each lepturus stings are treated with antivenom, but because the initial sting often appears minor, presentation to medical facilities is frequently delayed, making the role of late antivenom somewhat unclear for reversing already established damage.
Timing and the right approach are key everywhere, it seems. Now let's talk about spiders, another group that often gets a lot of sensationalized attention, but whose true medical impact and diversity are worth understanding in detail. What are the key players here?
Indeed. Spiders exhibit vast numbers and great species diversity. They fall into two broad taxonomic groupings when it comes to medical importance. The more primitive mygalomorphs include several medically important species, especially those infamous Australian funnel web spiders of the Atrax, Hadronaic, and Illawarra genera. They're known for their aggressive disposition and potent venom.
Funnel webs, right. Scary reputation.
They earn it. Then there are the far more diverse araneomorphs. Here, the main clinically important species are found in the genera Latrodectus, commonly known as widow spiders, like the black widow, Loxosceles, the brown recluse spiders, and Phenutria, the highly venomous banana or wandering spiders from South America. While spiders and spider bites are common across the globe, it's generally only these specific genera that cause medically significant effects in humans.
And what kind of effects do they cause?
In most cases, it involves that neuroexcitatory envenoming we discussed, which can sometimes be as severe as a major scorpion envenoming, notably from the Australian funnel web spiders, leading to profound autonomic storm effects.
Okay. What about the recluse spiders? They're different, right?
Yes, Loxosceles sbp, the recluse spiders, cause an often painless bite initially, but then it slowly develops into a characteristic local skin necrosis, often forming a bullseye lesion. And sometimes it can cause a severe systemic illness, similar to that caused by the Iranian scorpion, Hemoscorpius leptris, with similar lethal potential due to hemolysis and renal failure.
So they can be dangerous systemically too, not just locally.
Correct. For most of these medically significant spiders, antivenom remains the key treatment and can be life-saving in some cases, like with funnel webs. There has been some recent controversy. Studies suggesting that anti-latrodectus antivenom is ineffective for widow spider bites.
Oh, but isn't that standard treatment?
It has been for decades. These newer studies haven't been confirmed by independent research, and they stand in stark contrast to decades of positive clinical experience worldwide, where antivenom has been shown to rapidly relieve severe symptoms like pain and muscle spasms from widow bites. It just highlights how new research can sometimes challenge established clinical practices and the ongoing need for robust evidence.
Interesting debate there. Okay, shifting gears slightly. Paralysis ticks, you mentioned these earlier. How common are they and how do they work?
Right. Most ticks are just vectors for various diseases, transmitting pathogens like Lyme disease or Rocky Mountain spotted fever. However, a few specific species found in Australia, North America, and parts of Africa can directly cause flaccid paralysis through toxins present in their saliva.
Toxins in the saliva.
Yes. These toxins act as potent presynaptic neurotoxins, disrupting nerve signals to muscles similar to some snake venoms. Clinically, this leads to a gradual onset, ascending flaccid paralysis. Weakness starts in the legs and progresses upwards towards the trunk and eventually the respiratory muscles.
Ascending paralysis. Is there an antivenom for this?
No. Crucially, there are no antivenoms specifically for tick paralysis. Treatment relies entirely on the meticulous and complete removal of all ticks attached to the patient, making absolutely sure the head parts are extracted.
Gotta get the whole tick out.
Every single one. And then providing comprehensive supportive care, including intubation and mechanical ventilation if required, especially if respiratory paralysis develops. Thankfully, once all the ticks are removed, the paralysis usually resolves within about 48 hours as the body clears the toxin and those nerve endings repair.
Good to know it's reversible with removal. Now, what about venomous insects? You said most single stings are about allergy, but what are the exceptions for primary toxicity?
Very few cause significant envenoming from primary venom toxicity, but there's some critical and fascinating exceptions. Among venomous lepidopterans, that's moths and butterflies, but in this case, they're caterpillar stage.
Caterpillars.
Yes, specifically the notorious Lenomia caterpillars of South America, particularly Brazil. These seemingly innocuous caterpillars possess numerous protective venomous spines.
Spines, okay.
Upon contact with skin, these spines discharge a potent procoagulant venom. Venom can lead to a progressive and sometimes fatal consumptive coagulopathy, using up clotting factors, eventually resulting in terminal hemorrhagic events and/or multi-organ failure.
Just from touching a caterpillar. Wow. Is there treatment?
Yes, treatment for Lenomia caterpillar envenoming includes the use of a specific Brazilian antivenom, alongside extensive supportive care for the bleeding and organ dysfunction.
Okay. What about hymenopterans, bees, wasps, hornets, ants? You mentioned mass stings.
Right. Hymenopterans have modified ovipositors in their abdomen that act as stings connected to venom glands. The quantity of venom injected in a single sting is generally insufficient to cause significant envenomation from primary venom toxicity. But as we said, many of these venoms are potently allergenic, so a single sting can cause severe, sometimes fatal anaphylaxis in sensitized people.
Right, the allergy risk.
The real danger of primary venom toxicity arises from mass stings when hundreds or even thousands of these insects attack in a swarm.
Just from bees or wasps.
Yes. This can completely overwhelm the body's systems, leading to life-threatening systemic envenoming. This is often characterized by intravascular hemolysis, mass red blood cell destruction, disseminated intravascular coagulation, DIC, shock, and multi-organ failure. Africanized bees are a particular risk for such mass attacks in South America and now parts of North America due to their aggressive swarming behavior.
Africanized bees? Yeah, you hear about those.
Also, the giant wasps and hornets of Asia can similarly cause severe systemic envenoming with multiple attacks. And invasive ants like Solenopsis spp fire ants are colonizing new regions and can cause both severe allergic reactions and very unpleasant local reactions with their painful stings.
Okay, a lot to be aware of there. Finally, let's dip into the marine venomous and poisonous animals. What are the key threats from the ocean?
The marine environment is just teeming with animal life, and many species utilize toxins either self-produced or acquired from their environment for defense or predation. Many of these can cause adverse effects in humans, either through a direct venom effect from bites or stings, think venomous spiny fish like stonefish, sea snakes, stingrays, jellyfish, sea urchins, certain starfish, cone snails, and selected octopuses, or through poisoning if the animal's eaten. Things like fugu fish poisoning, ciguatera, scombroid, or various types of shellfish poisoning. That's toxinology, but slightly different from envenomation.
Right, poisoning versus envenomation. Focusing on envenomation, what about antivenoms for marine creatures? Are they common?
No, antivenom availability is quite limited globally for marine animals. Specific antivenoms exist only for a few species. For sea snakes, which can cause rhabdomyolysis and odor paralytic neurotoxicity. For box jellyfish, known for causing very rapid cardiac collapse. And for stonefish, which cause excruciating sting site pain.
Only those three.
Oh, yeah.
Is there any general first aid for marine stings?
Yes, a general and often remarkably effective approach for many marine venoms is heat therapy.
Heat, not cold.
Heat. Many marine venoms are thermolabile, meaning their toxins are denatured or inactivated by heat. So, hot water immersion or a shower at approximately 45 degrees C, which is about 113 degrees effort, basically as hot as the patient can tolerate without actually burning themselves, is surprisingly effective at reducing local pain.
For which ones?
Particularly for jellyfish, stinging fish like stonefish or lionfish, and stingray stings.
Good tip to remember. Any other specific marine dangers we should know about?
Yes, a few key ones. Stingrays. Their venom causes severe local tissue damage, not only through the physical trauma of the sting from their barbed tail spine, but also through the direct venom effect, which can be cytotoxic, cell killing. Wounds from stingrays need to be adequately explored to ensure no spine fragments remain, thoroughly cleaned, and typically allowed to heal by secondary intention, meaning left open initially to prevent abscess formation.
Okay, thorough wound care for stingrays.
For bites by the small but incredibly lethal blue-ringed octopus and stings by cone snails, the venoms are remarkably rapid-acting. They can cause early cardiovascular collapse and profound flaccid paralysis. Even though the local wounds might seem trivial, often just a small bite mark supportive care, especially aggressive respiratory support with mechanical ventilation, is absolutely crucial in ensuring survival.
So don't underestimate a small bite from those.
Absolutely not. Lastly, sea urchin and venomous starfish wounds can result in multiple penetrating spines embedded in the tissue. These cause persistent pain, granulomas, inflammatory nodules, and act as a nidus for secondary bacterial infection. Surgical removal of these spines can be quite difficult and often unrewarding because they're brittle and break easily, so prevention, like wearing protective footwear while waiting, is really key.
Outro.
Wow. This has truly been an incredibly vast and intricate world we've explored today. I mean, from the molecular intricacies of venom composition to the global epidemiology of human encounters, this deep dive has really revealed just how complex envenomation truly is. We've dissected the precise mechanisms of how these toxins wreak havoc on the human body, understood the critical importance of swift and correct first aid, and seen the nuanced, tailored approaches required for modern medical treatment. So, what does this all mean for you, the listener? It means understanding that knowledge, even of something so specialized, truly is power when facing something as complex and potentially life-threatening as a venomous encounter. It empowers you to discern accurate information from sensationalism and appreciate the profound sophistication of both these biological weapons and our modern medical responses.
Absolutely. And if we connect this to the bigger picture, this deep dive highlights the constant need for vigilance and accurate information, especially in a world where human travel and access to these animals, whether through changing ecosystems or the exotic pet trade, is steadily increasing. The global burden of envenomation is immense. The diversity of venoms and their effects is really quite astonishing, and the critical role of geographical knowledge in diagnosis and treatment cannot be overstated. We've also touched on how our understanding in this field is constantly evolving, with new clinical information and syndromes continually emerging, even for species we thought we knew well. It's constantly pushing the boundaries of toxicology and emergency medicine.
Exactly. You know, consider how the very same evolutionary pressures that led to such specialized and potent venoms also drive the constant innovation in medical science to counter them. It's like a biological arms race playing out in real time, a testament to both nature's sometimes terrifying ingenuity and human resilience.
That's a great way to put it. And that's why continued curiosity and critical thinking are so essential. Even for those of us deeply immersed in this field, there's always more to learn and discover. I'd encourage you, if you're interested, to explore reliable resources like toxinology.com for further information, as even the experts are continuously learning and adapting to new discoveries in this truly fascinating area.
A perfect thought to end on. Thank you for joining us on this deep dive into the complex world of envenomation. We hope you feel incredibly well informed and empowered by this knowledge. Join us next time on the deep dive as we plunge into another fascinating topic.